All right, well, why don't we get started? I'm Judy Brenner. I'm one of the associate deans here at the School of Medicine. Many people on this call know me, but not everybody. I'm an internist and the associate dean for educational data and analytics. And I am so pleased to be able to this time have a voice, because the last time around, anyone who was there, I did not have a voice. I had COVID voice, but I'm so honored really to introduce Dr. Pangaro. And I'll be telling you a little bit about him in a moment. But first, I think we're going to have a poll dropped in the chat to find out who is here today. So please take one moment to do this. And I guess we'll see the results. There we go. We have a lot of faculty and staff. I think they're faculty from many places here, so welcome. All right, so I am, as I said, pleased to bring to you Dr. Pangaro, who is a professor of medicine at the Uniformed Services University of the Health Sciences. I would call Dr. Pangaro an educator of educators. When Dr. Pangaro says something or writes something, I think we all know that we should take notice, whether it's on paper or in a meeting. It's always something that will certainly enrich the audience. His scholarly work is for clinicians to evaluate the competence of trainees and has been disseminated all over the place, you name it. From 2009 to 2014, Dr. Pangaro was one of the faculty leaders of curriculum redesign. So he has experience in this realm that we're walking into for the Uniformed Services University School of Medicine. But he's done so much. He's personally evaluated and given feedback to several thousand medical students. I think he can, it's safe to say that he will be able to tell us a whole lot to help us understand and think a little bit more broadly about our curriculum renewal process. And just the last note is that the first thing that made me think, oh, this, Dr. Pangaro would be a great person to come is a talk he gave back in IAMC, this was in June, where it's almost like he knew that our school was about to undergo a renewal process and we were thinking towards the future. So his talk at the time was like, what should the graduate of the physician of 2042 know? So I was like, oh, couldn't be more perfect. But today what he'll speak to us about is curriculum renewal. What is it and why is it? So with that, I want to just introduce you, Dr. Pangaro.
Thanks, Judy. Thanks very much. I will share my slides in a minute. Thank you for the introduction. I should say I'm really glad to be talking to Zucker Northwell Hofstra. I've been working with your colleagues at your school from its inception, and you may already know you're in advance of what most people in medical education are doing in the United States. So my speaking to you gives you my perspective. I'm what passes as an expert in this field, but as an endocrinologist who takes care of patients, I have a molecular understanding of how thyroid hormone interacts with the nucleus of a cardiac cell. When I take care of my diabetic patients, I can look at thousands of patients randomized into two different arms of a study, a true experiment, to see what will happen. I think we have nothing like this yet in medical education. So we're all at the very, very beginning of the process of trying to create some kind of rigor, standardization, whatever word you want for that in medical education. And I understand my own comments in that way. I will speak forcefully. I grew up in Jersey City, just across the river from you, so I'm louder than most people and my own colleagues, and I speak forcefully, but I don't confuse my own vehemence with certainty, and I am certain you won't either. I'm now going to share my screen so we can see my slides. I don't know how to, you are screen sharing. Good. Try to get rid of the images. And I will share my slides at the end with a copy of them with Judy and Elizabeth, so that if you want to take a look at you can. So curriculum renewal, what is it? Why is it? Is my talk. I'm going to begin with a question for everyone. Our world is changing in medicine and practice patterns and costs and resource constraints. There are all sorts of new technologies. There are national uncertainties, global uncertainties. And many of these things mean we have to rethink how we're doing medical education. And given that, what is one thing that you personally as an individual would want to preserve in your own institution if there has to be change? Could I ask you to write that down in the chat? And this will be of use to Judy and the leaders at Zucker Northwell, but it will also help you see where I'm going. So I'm going to just take a moment to ask you to type into the chat. Good. I'm seeing humanism appear many times. Mentorship is appearing. Person-centered care, curiosity, excitement, empathy, using sound science. Well, this is wonderful. And I think it reflects your institution and why and how you were formed and its leadership from the very beginning. Curiosity and excitement, empathy. This is great. I'm going to close my own chat here for a minute if I can figure out how to do this and just continue with my talk. Let's see. Disclaimer. The opinions and assertions expressed herein are those of the author and do not reflect the official policy or position of the Uniformed Services University or the Department of Defense. And I have one disclosure. I lead the Systems of Assessment course for Harvard Macy. They give me an honorarium, and I use some of the same materials in this. Here's the general discussion. How can we define curriculum and curricular renewal? Why would we want to do this? And what are the methods that we need to preserve to foster independence and create capability in students? And my theme today is the notion of competence, and we'll talk a little bit more about what that means, but the emphasis on competence places faculty judgment at the center of everything that we're doing, including your curricular renewal, your curricular redesign. And this will be one of my themes today, probably the most important theme, that the faculty are at the heart of things. It's about the students, and it may be directed by the leaders of the curricular design process, but nothing works unless the faculty can make it happen. A few terminology things. I want to distinguish syllabus, which is content, which is a list of topics to be covered, and curriculum, which etymologically means erase. Essentially, it's what we do to learners. That's sometimes called pedagogy, and what we ask the students to do. But syllabus is basically the what, the content, and curriculum is the how. Now, there are many terms for curricular revision or curricular change. At Zucker Northwell, you're referring to it as renewal, making it new, updating. The traditional term was reform, which means a reshaping, a reforming. And it also has, for some people, a pejorative content that you need to reform it, something wrong with it, we need to fix it. Redesign, which is what we called it at our school initially, planning anew, as if we were restructuring things. And I also like the term curricular revision, seeing things differently, because I would like students to see things in a certain way. Overall, in everything we do, what I'm looking for in the students, what I want them to see and develop, is a commitment to understanding mechanism, whether that mechanism is at the bottom of the triangle, which you see in front of you, molecules, genes, At the center of the triangle, the patient, clinical science, are at the very top of the triangle. For me, that's the military healthcare system. It's the state, the nation, what we're now calling system science. And what I would like students to feel in this is that they're committed to X-ray vision, that they see below the surface. If it's a patient with lupus nephritis, they don't just see hematuria, a rash in joints, they can visualize a glomerulus. If it is at the level of healthcare system, they understand how the system shapes what has happened to the patient in the past and what may affect them in the future. So I'm using X-ray vision as a commitment to understanding mechanism and pathophysiology. And I'm deriving this notion that the word physician, physiology, physics all comes from the Greek word for nature, physis, nature or process. And I see the goal of any curriculum, new or old, as a way of making sure the students understand what the promise of expertise looks like, that they are committed to understanding things at much more than a superficial level. They are not being trained as physician's assistants, or in the military, we call them corpsmen, or nurse practitioners with a limited scope of practice. They're more like doctors of nursing practice with a more advanced, but you have to, the commitment is to mechanism. So over the years, why have we revised things? I think you know that more than 100 years ago, the Flexner Revolution was that there was so much that we had learned about basic sciences of physiology and organic chemistry coming out of Europe in the late 19th century that we needed to put more basic science. In the 1990s, the fact that medicine was becoming a business and people were very concerned about the threats to professionalism, early clinical experience and an emphasis on interpersonal skills and standardized patients was, as a way of assessing clinical skills, were built into curricular redesign at the time. So why do we continue to change things now? Well, number one at the top of my screen is the practice of medicine has changed dramatically. And climate change and pandemics and unstable national politics, the electronic health record, artificial intelligence, machine learning, all of these things are factors. Integration has become a priority in the accreditation process, and that everything we teach must be relevant to patients and that we're building social awareness. The fact that some students come in extremely well prepared in biochemistry and general science and they proceed quickly through the curriculum has led to new curricular opportunities, such as master's degrees in public health, business, in my own school, health professions education. Student learning styles have changed. Adult learning and technology has now made a lot of changes. So there's a lot of reasons why we continue to change. Over the next few slides, I'll review some of the basic trends in curricular form or in the last decade or so. I'm calling this post-Carnegie 2, the report by O'Brien and Irby about that updated the Carnegie report. And some of the things we've seen are changes to curricular structure and organization in about 25% of schools with a shortened pre-clerkship period. About 20% of schools have realigned USMLE Step 1 to be after the clerkships. Here's a brief report from one of my colleagues, Dario Torri, reporting that initially Step 1 scores increased significantly following curricular revision and after controlling for MCATs and undergraduate GPAs. So it looked like these experiments have worked. We have increased the opportunities for electives in the clerkship year. Many schools are starting a 3-year medical school track. And in front of you now, you see a typical curriculum in which in red at the top, the pre-clerkship period has been shortened from 2 years to 1.5 years. In blue in the middle, the basic clerkship blocks are now starting halfway through the second year, thus leaving a lot of extra time after the clerkships for individualization. So standardization, that's a term from the O'Brien book. And Molly Cook was the first author on that book, Bridget O'Brien, Dave Irby were the other authors, that that standardization would be achieved by the end of the clerkships, and then individualization could take place. Further trends, reinforcing basic science in the clinical years was a big push. I'm not sure it really happened. Certainly a lot of schools have pushed for early clinical exposure, although I'm not sure we've gone far enough. Changes to curricular delivery, integration. Instead of having anatomy, physiology, biochemistry, many schools have moved from discipline-based courses to integrated modules of musculoskeletal, cardiopulmonary, renal, decreased reliance on lectures, pre-clerkship boot camp to prepare people. So there have been lots of different ideas been going on. What's nice about this is that there does seem to be some change happening. Here's an example of a pre-clerkship period. This is a year and a half across the big blocks are after a fundamentals module, musculoskeletal, cardiopulmonary, with lots of case-based learning and clinical skills streaming through the curriculum. So I'm just reviewing some of the ideas that your own group will have been looked at when you're thinking of revising your curricular again. Changes to assessment is the final thing I want to talk about in trends in curricular reform. Developing competency-based assessments, in other words, tasks, and not simply written examinations or what we're looking at to make sure that the students are progressing. A lot of schools have eliminated traditional letter grades, not only ABC, but even honors, high, pass, and are using basically pass, fail, or honors, pass, fail. And there's now also more emphasis placed on assessment tracking to try to decide what gets better over the clerkships. So basically what we have is a change. A prior article written by Sam Bloom from Sinai, I love this piece, 60 years of curricular reform without change. And what he said is partially the theme of my talk, that desired change cannot be accomplished by simply adding to and putting new things, adding curricular components. There has to be a change in the teaching environment or in what we mean by socialization or a profession. And this is these areas of Zucker, Northwell, Hofstra has already been leaders in what you call behind the classroom. The idea, for instance, that was introduced many years ago that while you were studying cardiology and cardiac physiology, students would be trained as emergency medicine technicians. And they wouldn't just study Einthoven's triangle and an EKG, they would participate in resuscitating patients. And early patient interactions are already part of your curriculum. Now, the major theme, the major force that is pressing everyone right now is an understanding that medical education is a public good. The dollar cost of medical care in the United States, where it's 20% of the gross domestic product, illustrated on the lower right-hand corner there, and the human cost, the fact that we make mistakes, and the Institute of Medicine's monograph, To Err is Human, told us that 100,000 plus patients were dying every year because of some mistakes, placed emphasis on reasoning, decision-making, high-value care, and more recently, health system science and competency-based medical education, which is what we're going to talk about for the next few minutes. So what is the problem that CBME, or competency-based medical education, is trying to solve? The strategic goal is to help everyone understand that we get that medical education is a social good, and that we, excuse me, in the House of Medicine, we are serving a public trust. That's the strategic goal. The tactical goal is to prove that we mean it and that we should retain control of funding and control of medical education by documenting that students and residents have achieved the necessary functional level, not simply fund of knowledge, but the functional level needed to move to supervised practice and internship or unsupervised practice. This has also moved us away from analytic frameworks like knowledge, skills, and attitude, or the ACGP competencies, excuse me, to synthetic frameworks, the first of which was RHYME in the 90s, but now milestones and EPAs, in which knowledge, skills, and attitude must be combined by the student or by the resident in a task successfully. And this requires the kind of adaptive expertise for which education and not simply training are needed. Now, this move to CBME has meant an emphasis on documentation and measurement, and it has produced a change in curricular redesign and in our work. Here is the traditional way we plan curriculum. We have educational goals. Then we plan the how a student should learn. That's the curriculum. Then we create the process of assessment and evaluation to figure out whether or not the student has achieved what is necessary. Sorry. And then we can take the educational action of feedback if the student needs further improvement, or the administrative action of grading if we need to decide to advance the student to the next year or to internship. This has been the traditional model. It is now a little bit passé, and now you have your educational goals, and CBME, competency-based education, says, the first thing you do is you say, how will you assess it? So you actually plan your assessment at the same time or even before you plan the curriculum. In other words, the premise is teach to the test. The premise is that we can come up with tests and observations that are so good that teaching to the test is okay. I think you can hear a little skepticism in my voice, but this is one of the premises of competency-based education. That once you think this is what you want your student to achieve, and you use the words a few minutes ago when I asked you, what do you want to preserve? Humanism, mentoring, and all these things, that not only can you visualize what humanism looks like, you can measure it. Not only can you visualize what successful clinical reasoning looks like, you can measure it. So this is part of the problem. What I'm going to be emphasizing is that it's very, very hard to measure the stuff that's really important to you. But faculty have learned over generations how to make these judgments, and therefore faculty are going to be critical in the process. So when we say, how do you test for a competency? Well, you know the traditional distinction between summative and formative, which is on the screen in front of you. And summatively, if you want to have a blueprint to how to determine that a student is ready for internships, there are various what I'll call in vitro type of tests because they're controlled by administrators or clerkship directors, multiple choice tests, OSCEs, and these can be standardized. This is one of the virtues of these in vitro tests, and they can be standardized and quantified. And then there are in vivo observations that are made by faculty. Formatively, we use in vivo observations using real patients who are often complex and contextual, and these can't be standardized. In the pre-clerkship period, with an OSCE, we can see whether students have learned the idea of heart failure, pneumonia, and pulmonary embolism. And in such standardized examinations, whether paper cases or in objective structured clinical exams using standardized patients, every patient with pneumonia has a fever. But we all know that in the real world, in vivo, not every patient with a pneumonia does have a fever. Or even if they do have a fever, they may have 4 or 5 other critical problems like metastatic lung cancer, thyrotoxicosis, diabetes, depression, which means that when we are looking at the non-standardized cases that students have to see, they don't always look like a prototype, and this requires faculty to make these observations. So in the pre-clerkship period, while we're still looking at prototypes of heart failure, pneumonia, pulmonary embolism, we can use in vitro tests, multiple choice tests, OSCEs. But in the real world, in the clerkships, and certainly in GME and residency, faculty are at the heart of the matter. So what is it then that what is it that we do when we have direct observations by faculty. What are they looking at? Well, for a moment, I'm going to drop into this ACGME model, which you use as a way of describing your own goals and objectives. It's on your website. The so-called 6 ACGME competencies: medical knowledge, communication skills, professionalism, patient care, system-based practice, practice-based learning, and improvement. In my way of thinking, there's only one competency: patient care, and all the rest support it in one way or another. What I'm after here is that you can assess medical knowledge with an in vitro multiple choice test. You can assess communication skills and even some procedural skills with task trainers and simulations. But you can only assess patient care in vivo with complicated real-world patients using faculty. So what I'm basically saying is, behind the scenes, we move from what might be called the analytic framework for competence. This is the Epstein 100 standard definition of competence: the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual. And this is an analytic framework in which competency is refracted into 6 or 7 different things. So, as opposed to this, we have the synthetic terms that I introduced about 25 years ago, in which competence is the ability to give to each situation all that belongs to that situation and not a lot of excess. Each patient, real patient, not standardized, not in vitro, requires a unique mix of something in the head, something in the hand, and something in the heart, KSA. Those 3 attributes of Bloom, knowledge, skills, and attitude, are synthesized, combined in a unique contribution for each patient. And whether or not successful or not, only faculty can judge. So once again, at the heart of everything we're doing in curricular redesign, I think we need to place faculty. And somehow in the faculty, we have to internalize some standards for judgment, so that the advice I give to the student today helps the student with Judy Brenner tomorrow, or Dave Battinelli the day after that. If we can't standardize and get some consistency across teachers, then there's very little reason students should trust faculty judgments. And in fact, if students can't trust faculty judgments, then the whole concept of professionalism is nonsense. So standardizing the faculty is essential for society and students to trust. So in curricular renewal, what role do we give to faculty who are really, really busy people? There's a big trend now in the United States that came out of Europe for entrustment of students. I'm really more interested in entrustment and support of faculty, because it's logically prior. If you cannot trust the faculty's judgment, then judgments about students' entrustability or readiness would be suspect. So again, in curricular redesign, I urge you to say, what is going to be the role of the faculty in fostering the independence of students, their progress towards independence, towards internship? And what is the support that the chairs and the dean's office are going to give the faculty in order to do that? The barriers to evaluation are cognitive, social, emotional, logistic. And my contention, cognitive, social, and logistic, is that faculty are actually pretty smart. Basic scientists are smart. Clinicians are smart. It's not that we need somebody to tell us what the framework's going to be, whether it's competencies, EPAs, rhyme. Faculty are smart. The main problem in getting good evaluations is a social emotional relationship between the teacher and the student, and having time to observe the student and give them feedback. So again, since I'm saying in CBME, competency-based education, to assess competence, and by competence, I mean readiness to deal with real patients. I don't mean dealing in an OSCE. You need faculty time. One of the principal things you have to do in curricular redesign is say, what can the faculty do? Cognitively, emotionally, and logistically. And how are you going to make that possible? Because remember, in CBME, you begin with assessment. You don't begin with curriculum. So you have to ready the faculty for this process. So before I made this distinction between the syllabus, the what we're going to do, and the curriculum and how. If it's a list to be covered, then you're adding things in, and integration is how the faculty arrange things in the schedule. In those diagrams I showed you before with the red and the blue blocks. But if curriculum is a way of doing things, then the real question is how the student arranges things in their own head. So it's integration, not as a faculty task, but as a student task. It's not a question of scheduling or what you put into lectures, but it's how students understand things. And I'm always arguing for simplicity. Curriculum is not content. Curriculum is a relationship with content, which is guided by teachers. And in medical school, curriculum is an invitation to progress from understanding into action. Now I'm going to digress for a minute, and this may be the most important thing I say to you, because this is how I define curricular success. I imagine I have an intern from my own medical school seeing a patient with me in the endocrine clinic, and the patient has Graves' disease, thyrotoxicosis, and that patient needs medication. I would be happy if my student, my graduate, could describe iodine metabolism and how methimazole worked. That would make me happy. But if, not knowing how methimazole worked, the student was not restless until they filled this gap in their knowledge, then I would drop dead with embarrassment. And this is my basic idea of evaluating a new curriculum. I would be happy if, but I would drop dead with embarrassment if. And what I want to see is the students' commitment, if you will, to mechanism. One, that they recognize that there's something they don't know. They have a concept of adequate knowledge. They have a search strategy. And most of all, they have a promise, a commitment to do it. And here I'm using the terms, of course, that they've internalized an idea of what is desirable. In the same way that the hypothalamus has an osmolality that it wants to maintain, or a blood sugar, the student has internalized this idea of what adequate knowledge looks like. In other words, they understand that professionalism is a promise. It's a promise of expertise and a promise of duty. And everything that we do in designing curriculum is aimed at helping them internalize what we, the faculty, think of is a promise of expertise and what duty looks like. And it must be internalized, because the internalization, the internal standard, the hypothalamus trying to maintain an osmolality of 287 milliosms, this creates the capability. And in the English language, the word capability could mean a faculty. And it's very interesting because we use the word faculty, mean those who create the capability in others. And we can do this somewhat schematically. This is a triangle from the Stanford Faculty Development Program. The faculty, the student are relating to patient care. And the whole purpose of the educational process is the progressive independence of the learner. In a word, in an image, at the end of the process of residency, certainly, the faculty need not be physically present. And during medical school, success means that the student has internalized the faculty's idea of what expertise and duty look like. It is not sufficient that the student knows how methimazole works, because there's going to be new drugs, there's going to be new diseases, there's going to be new therapies. The student has to have internalized a concept a set point in their head, in their hypothalamic equivalent, in their memory of what adequate knowledge looks like. So overall, in medical school, we have this movement from understanding into action, what I would call reporter, interpreter, into manager, educator. But the important thing is that just being a reporter, interpreter, coming up with the right diagnosis, this is a cognitive issue, primarily coming up with the right answer. But once we say a patient has diabetes, and we're now talking about insulin, oral agents, pills, weekly injection of dulaglutide or something like that, patients' choices and values, this is now an ethical consideration. And we've moved from simple expertise being greater than duty to expertise being as important to duty. Let me express this idea that you've talked about in your curriculum, and it's on your website, and you've been talking about it from the beginning. It's beyond the classroom. Can the correct understanding of working with patients ever be achieved in the classroom setting? You can get the basic ideas there, but can you really get it until you're working with real patients? Well, here's the problem. The patients, most of us, are in a 3-act play, if you will allow this metaphor. And we see the patient in the middle, in the second act, the patient's in clinic. And then we try to reconstruct what happened at home beforehand by doing a history and physical. And then we have to imagine what's in Act 3 when they go home, so we know they can actually take care of their diabetes at home or wherever else they're doing. So the patient is in a 3-act play, and we're only in Act 2, which means that if we give awards like a Tony Award or an Oscar, we can only get the supporting actor award. We're a supporting actor in someone else's play. And since we know that social determinants of disease determine as much as 40% of the variation in healthcare status, it's 4 times as much as what I do in the clinic. What is our part of a problem to fix this? And can this really be done in the 20th century model? What would a 2042 curriculum look like? Would it still look like the Flexner 2+2 here, seen in the triangle on the right? 2+2, from molecules at the bottom to health system at the top. We moved from an apprenticeship model in the 19th century to the academic model. But is that adequate? And how do you deal with this? Can the understanding be formed in the context of curricula? And there have been several methods to try this. Spiral curricula, in which basic science and clinical science go through medical school. Your own School of Medicine's method with early clinical experience with real patients, supplementing, but still in a Flexner 2+2 type of model. How do we create this capability for students to become independent and internalize a set point so that they have a standard in their own head in which they judge their own performance, what they did, not who they are, and they begin to be very performance or competency-based oriented. So what would a mental model of what expertise and duty look like? I've already said that in the pre-clerkship period, the students develop prototypes of heart failure, pneumonia, pulmonary embolism, and then in the clinical years, they move from understanding to action. And most people agree that the pre-clerkship, preclinical medical education period should include the basic sciences listed there above, behavioral science, biostatistics, public health, and a few other things like that, critical assessment of the medical literature. But if we say overall, it's a movement from understanding into action, from the beginning of med school to the end, reporter, interpreter to manager, educator, and in my lexicon, system-based practice is a subset of manager and practice-based learning is a subset of educator. And then curriculum is understood as a series of invitations. And can you reconfigure the curriculum to be a series of invitations, helping the student first learn how to talk to patients with respect and privacy at the very first weeks of first year, and being able to describe basic symptoms, the way a law student, you don't have to be a medical student to describe chest pain. But to go to interpreter, you now need knowledge to understand pathophysiology. And then you move on. Can you possibly create the curriculum as a series of invitations? And the rhyme scheme does this. I know many of you are familiar with this, but basically it's the same rhythm as history and physical assessment and plan. You see something, you think about it, you do something. And I want to show you that this basic framework here on the left of rhyme, reporter, interpreter, manager, educator, can be used as the framework into the list of EPAs, which many schools are using. Remember, the EPAs from the AAMC are not a framework, it's a list. And doing a history and physical, documenting a clinical encounter, all of these things can be used to populate the idea of reporter, prioritizing a differential diagnosis, interpreting common lab tests or interpreter, and so forth. So basically, we have this framework in which to encourage students, to invite them, first to be reporters, then to be interpreters, then to be managers, then to be educators. And so we have my problem with the students seeing the patient with thyrotoxicosis, and what's the role of the clinical faculty? Well, this is where I get very demanding, and although I sound very student-oriented, they think I'm really intimidating because I'm really ruthless about what they need to know. And I'm using the example here of a therapy, in this case, methimazole for an overactive thyroid. And I think you would all agree with me. You have to know, how does it work? Addressing the relevant anatomy or physiology. How good is it? Efficacy, short-term, long-term. How good is the evidence? Is it necessary, appropriate, or inappropriate for the disease under question? Or how bad is it? So basically, there are always, in my simple world, there's always three things. How does it work? How good is it? And how bad is it? And I basically expect students or residents to be able to answer these questions within 24 hours. My invitation to go from reporter to interpreter to manager is that they understand what a promise of expertise, in this case, knowledge, is about a drug. How does it work? How good is it? How bad is it? What would you need to know about a disease? What is it in its pathophysiology? What does it look like? What do we do about it? What do we need to know about a test? How does it work? How good is it? And how bad is it? And I actually give the students a card on two sides, which is seen more or less there. And as I said before, I'll give you copies of my slides. I want the students to internalize the notion of what constitutes adequate basic knowledge, what a promise of expertise looks like. Has the student not just learned methimazole, but have they learned what they need to know about any drug? Acquired a standard against which to compare. So have they internalized a set point? They have a standard, they have a mental model of what disease and expertise look like. And they must learn this in the pre-clerkship period and practice it in the clinical years so that they can apply it to all levels of our inverted triangle. What I'm looking for is an integration with the student so that they have systems thinking. Whether the system is how the body maintains gluconeogenesis, uses gluconeogenesis to maintain a blood sugar, or community health, they have a series of questions of what an adequate conception of Act 1, 2, and 3 look like. What is the system trying to do? What are the inputs? What are the outputs? What is the system trying to maximize? And so forth. So what does the student in the new curriculum bring to the situation? They've worked with patients from the beginning of medical school, so they bring a sense of duty. We, the faculty, have tried to teach them what expertise looks like, knowledge looks like. And in our own studies, 25% of the explainable variance in ratings in student clerkship performance is explained by their pre-clerkship GPAs. This is, for anybody who does educational research, understand this is a very high percentage of explainable variance. In other words, grading in the clerkship is not necessarily a popularity contest. It actually depends on what you know. So what should the faculty bring to the clerkship? Trust, expectations, and feedback. Trust that the faculty will be honest and consistent, clear expectations. And then what do these invitations look like in the pre-clerkship? The faculty member says to the students in a small group, what are some of the pathophysiologic mechanisms that might explain this patient's finding? What are some of the social mechanisms that might explain this patient's finding? It is an invitation to think out loud. In the clerkship, the curriculum should always be an invitation to interpret and possibly to have management suggestions. What are 3 possible factors that could explain your patient's problem? We don't expect students to be right. We expect residents to be right, but we expect students to spontaneously say, here are 3 possible explanations for the patient's pleural effusion. So we want the students to internalize what a promise of expertise and duty looks like. And the promise is made to the patient, not to the teacher, not to the test, or even to the healthcare system. So in summary, both policy and strategy, I would like students in a new curriculum to see it as a process in which they internalize what duty and expertise look like and are invited to progress. Faculty support and trust and create clarity and expectations. And deans and chairs see faculty as the key to success and provide support. To wrap this up, I would appreciate it if you would, and you've been asked to do this in prior talks in this series, what is something that you heard today that you think could apply to your own curriculum renewal process? Please type this into the chat. And then I will pause and see if there's any questions. Something you heard that might be of any use at all. I put my AOL email address if anybody would like to ask me for some, I will send copies of my slides, but if you'd like copies of our bibliography for our own studies of things, I'd be happy to send them to people, or if somebody wants to just chat. Elizabeth, I'm going to stop sharing my screen.
Okay. Well, thank you so much, Dr. Pangaro. That was terrific. You've given us so many things to think about, and thank you to everybody who's for adding your thoughts into the chat. We'll download everything so that we have this for our process. So now it's time for Q&A, and I'm going to invite anyone to either write a question into the chat, or if you just raise your hand through Zoom, and I will call on people. I'd love to get as many people as possible answering questions. So we're going to start with our dean, Dr. Bettinelli.
Lou, hopefully you can hear me. Thank you so much.
I can hear you, David. Thank you.
My mother would be jealous that I don't have a Regis flag hanging behind me. So. But
thank you for picking that up.
I think
Fauci graduated many years before I did.
Yeah. Okay, so love all the stuff. Assuming we can sort of get to where you're going, how would you do the assessment, and how would you transmit that assessment to the graduate enterprise so that they understood who they were getting, what the product?
Sure.
How
I know you're interested in that problem. All right, so let me use some basic information processing notions. We go from data to information to knowledge to action. Mm-hmm. When I observe a student with a patient, and I have a framework, I use RHYME, I can give the student feedback because I have information. I place my observations in the context. But I do not yet have any summative information to either render a grade or advancement or tell GME. So to go from information to knowledge is a sampling problem. A sampling problem. If you want to know whether a student is ready for internship in general, you sample across clerkships. So you have medicine, surgery, pediatric psychiatry, and you need a minimum number of observations in each discipline of skills like talking to a reporter skills, interpreter skills, basic manager skills. For a resident, of course, that's much, much higher. So for the general question, are you ready for any GME? The sampling is very, very broad. If the student is applying to psychiatry, and I know the psychiatry programs and what they're looking for, then I could actually say to a student who's now finished the clerkships halfway through second year, you've declared that you're interested in psychiatry. I know the psychiatry programs are interested in this. I can write you a better, stronger letter if I know what they want. And Dave, I'm quoting you, something you said just 2 or 3 nights ago, and is figuring out what they want and telling them how. But basically, my point is to go from information to knowledge requires sampling. And if it's specialty specific, the surgeons now want boot camps, right? They want everybody to they want me to tell them that they know how to do basic kinds of suturings and the different kinds of knots and stuff like that. So it's either very, very broad for a generic student or it's focused to the specialty. But it's a sampling problem, and you have to decide what adequate sampling is. We have some data on that. I think you know that to have an adequate sample of interpersonal and communication skills, it's between 5 and 10 patients at a minimum. For clinical reasoning, can you think like a psychiatrist or an internist? It's 10 to 20. So you have, in CBME, you would have documented. It wouldn't just be a gestalt. It would be documentation. So the answer to your question for me is blueprints. That's how you go from information to knowledge. And I have a whole talk on blueprints on how we do that, what it looks like for each specialty. And the blueprint could be clinical skills, it could be inpatient, outpatient, it could be medicine, surgery, pediatrics. There's the variety of blueprints, but that's the answer, I think, to the question.
Well, we'll take up some time with you, I guess, later to look at your blueprints. But it is a focus of what we're interested in, because we think we have a manageable number of students and an advanced curriculum, and we are struggling with trying to make sure that we can make sure that the graduate enterprise understands the capabilities of our students and how we best document that and transmit that information.
Yeah. Well, a curriculum revision that focused on that part of assessment would be quite an innovation. And it would enhance, if you will, the competitiveness of a school. If you had a record in which your students tended to get their GME of choice because you guaranteed GME, that would be impressive. Our school is a little different. We're in the military. All of my students must apply, but there are 60 Army students. And if 10 of them want to do internal medicine, they can only apply to 5 programs. And those 5 program directors, I've all trained about how to assess competence in a program. So they trust us. So we have some fairly specific kinds of ways we report to GME the readiness of a student. Trust is essential. Most deans don't want to have students left over at the end of the year, right? But in my situation, we want GME program directors to trust us. And because there's a small number of them, our students do not apply to 50 plus programs. They apply to 5.
Well, I mean, I think you're pointing out some of the issues, which is that there is very little, or not as much as there should be, trust between the GME programs and the average medical school for information other than what they've been relying on, which is sort of standardized test information and rankings.
Yeah, and I think the LCME and other groups are trying to standardize this with the MISP and other kinds of things to trust it. Basically, a letter of recommendation should read like a research article in a journal. This is our methodology. These are the results. This is the interpretation. They don't. They read like a novel.
Any other questions? Oh, Dr. Ahuja.
Hi, thank you, Dr. Pangaro. That was a very thought-provoking talk. I wanted to ask you about the internal set point. And I mean, I think that is a goal of all faculty, but is there a way to expedite that without getting to the point that you realize like, oh, this patient's responsibility is mine, and then you start creating that set point? How do you create that earlier
Yeah.
on in UME?
The problem for clinical faculty is very difficult. So when I was chair of medicine for 10 years and had 1,000 faculty between Bethesda and Honolulu. And the first thing I do is I respect faculty and I don't impose my constructs as an educator on them. They're so busy trying to save lives, right? They have to diagnose the patient, diagnose the learner, and kind of diagnose themselves. So the first thing for me is respect for the faculty. And I ask them to do what they can do. So the faculty has spent 7 years, at least, writing histories and physicals, history and physical assessment plan, right? You see something, you think about it, you do something. So my RHYME framework, reporter, interpreter, manager, educator, they get in 5 minutes. They get it immediately. The second thing is I do not ask faculty to rank students, whether in milestones or EPAs. That is counterintuitive. Faculty make diagnoses. This is heart failure, this is pneumonia, this is a pulmonary embolism, or your equivalent in psychiatry or obstetrics. That's what we do. This is a reporter, this is an interpreter, this is a manager. So I'm interested in construct alignment for the faculty. Dr. Uji, do you hear, oops, something, I just lost you all.
I can hear you.
I'm sorry.
No, that's okay.
So in order to understand the central role of faculty, I go where they are, not where the ACGME or the LCME wants them. Now, this is a little heretical. You understand that. I think you know I'm being deliberately pushing back, and I've written essays, 2 cheers for the milestones, and being critical of this, is that I don't think you can be fair to patients or students if you're not fair to faculty. And my faculty, internal medicine, you know, the burnout rate is enormous. This is even before COVID and the business. So the first thing I say is I want them to do something they get like this. And the imposition, if you go to your website and you look at the list of expectations in medical knowledge, interpersonal communication skills, it sums up to more than 100 items. The cognitive load is enormous. It's unworkable. So the first thing is to have respect for faculty and what they do, what they have been trained to do, make diagnoses by classification. The second thing, and I think this is important, we have done studies, I can send you a bibliography, and that proves what you know to be true. Faculty will tell you what they will not write down. So we make a point of talking to faculty every 2 to 3 weeks. And we can detect bias in both directions. They like the student because the student's already going into their specialty, or they dislike the student for some other reason, because we're talking to them. It's a conversation. So I don't think whatever the framework it is, RHYME, EPAs, milestones, you should ever just say it's okay to give the faculty member a written evaluation form or something on their cell phone and think they're going to use it, because the problem is not simply cognitive, it's affective, social, emotional. And nothing is more important to me than that the students trust the evaluations. Because if they don't, then the concept of professionalism, which is important to you all, is crap. If the faculty cannot trust the evaluation. So another way of saying this, I would be happy if the evaluation I gave a student, the feedback I gave them today, helped them with you in your setting tomorrow. But I would drop dead with embarrassment if it made things worse for them. So consistency of faculty is, to me, the core task of any curricular redesign. Anything else is crap. I usually say bullshit, but I won't say that in deference to the company. But I feel very strongly about this. I feel very strongly about it. On this phone, we can analyze the words. You know, people have done this for letters of recommendation. words that are patronizing towards women or not. But if I want to know whether this faculty member has a bias against this student, I can hear it in their tone of voice. So, and I have clerkships in San Antonio, San Diego, Honolulu, and there's somebody there who would sit down with you every few weeks and talk. And if you sound like you just don't like this person, my clerkship director is trained to hear and to say, it sounds like you don't like this student. What's going on? Or it sounds like you think the student is okay. What does that mean? Tell me more. So I'm now on my hobby horse here, because this is an obsession of mine. This is a little bit beyond what we were going to talk about, but I believe faculty are at the heart of the matter.
I agree. Thank you.
Yeah. Okay. I'll stop.
No. I just want to say I agree with you. I was formerly the clerkship director for all the ambulatory clerkships, and definitely you have to meet the faculty where they are. And
in the same way that the CEO of the hospital sees the faculty as a cog in their machine, there is a tendency for the LCME or the ACGME to see faculty as cogs in their machine, reporting milestones to Chicago every 6 months. And I know that Battinelli would never do that. That the dean's office there, I know you people, but I know how exactly you treat the students.
Yeah.
But the tendency to standardize, to optimize, and all that business jargon contaminates us a little bit. Let me push it further. Do you know the phrase workplace-based assessment? It gives me a rash. This is not a workplace. There is a promise made to patients. The physician, the scientist who teach our students are not in a financial contractual relationship to patients or to students. So I use the term WBA, workplace-based assessment, but I think it's symptomatic of everything that is going wrong in national trendiness. There are good things. I understand why the ACG and the LCME do what they do. I believe in medicine, medical education is a public good. But I think we have to be careful inviting the faculty member to rank or rate the student on a 1 to 9 scale, or 1 to 5, whatever it is. I think we have to be careful of that. This wasn't the subject of my talk, but
we love it.
You pushed a button.
We appreciate it. I think Dr. Kwiatkowski has a question.
Sure.
Yes, my question is a little bit different. I mean, how do you design and handle student feedback? I mean, sometimes I feel that we too heavily rely on student feedback when they don't necessarily know what's best for them.
Yeah. Well, there has to be trust. The pillars of education and the pillars of leadership are the same. Trust, clarity of expectation, and honesty and specificity of feedback. And as chair, I had to work very hard to make sure that comments in which students get angry at faculty for being explicit don't hurt them when they get promoted to associate professor, because a lot of places that's an issue. So for me, feedback, I want the student to trust that the feedback they're given by a teacher today will actually be the same framework used for summative evaluation at the end. In other words, we're not going to change the rules. And that an individual teacher, say if the student is worried that Pangaro is a son of a bitch, and you're screwed if you got Pangaro, whereas if you get Battinelli, who's a nice guy, you're lucky, then there's no trust in the system. So it is up to me, the leadership, which includes the chairs. In my institution, it is chairs who get people promoted from assistant to associate professor. It is chairs who determine workload, not deans. So I want the chairs to be involved in everything that we do. Now, I was dean for a year. We didn't mention that, but I worked very hard to make sure that the chairs understood that I held them accountable for empowering the faculty and making sure the faculty had the time and the training to do this. But basically, there's no greater tribute to anyone than being honest with them. So the feedback must be honest. But the student has to know, let me say it this way, this is probably the best way. The student has to know that when Pangaro gives feedback, it is not idiosyncratic. That the feedback that Pangaro gives is the same feedback that you would give, or Battinelli would give, or Alice Fornari would give, or Brenner would give. Do you see what I mean? We're all on the same page. So the student can say, if I follow this guidance, I'm going to get better, and my grade is going to get better. And that's the work of the administrators, of the clerkship directors, the course directors, the associate deans, and I believe the chair, to make sure that the clerkship directors and the people giving the feedback have the time and the training to be consistent.
Great, thank you.
Dr. Rakowski, have I answered your question?
Yes,
Yeah.
We have one question in the chat from Dr. Barone. He says that as a program director, even more than knowledge or skills, I want to know the student has developed a sense of professional identity. MSPEs are rarely honest in this area. How do you
Yes.
identify outliers, and how do you report them in your MSP?
This is a very difficult problem because right now, coded language is what is used. You see this coded language, certainly by gender. We're beginning to understand it in terms of race, but the person writing even a chair's letter or the dean's letter doesn't want to have a student left over at the end of the year. You know what I really think the answer is going to be? It's going to be lawsuits. Right now, 95% of lawsuits having to do with grading are failure to graduate. You didn't graduate my client. But there's about 1 or 2% that are wrongful graduation. You knew this student was a miscreant, and you still graduated them. This all began with Maxine Papadakis' study, first in California, and then with colleagues from Pennsylvania and Michigan, about the trail of unprofessional behavior. So I think once the lawyers understand that if we graduate somebody who is unprofessional, eventually the medical school or the residency can be sued, then that will be the primary pressure. I'm sorry it's that way, but I don't think the students are going to beg for honesty. Even in my situation where they're going to be deployed and they're going to be in Iraq or Afghanistan with people we graduate, that you know, it's you don't want to leave anybody behind. That's why I said before that the problem of evaluation is not primarily or only cognitive. It's social, emotional, as well as logistic, having time.
Well, it's David again. Where do you think the grades issue is going to land in the next few years?
We tried to get rid of honor. We went from A, B, C, D to honors, high pass, pass, fail. And we tried to get rid of honors because of the data that shows the benefits of not having and in our GME community screamed, you can't do that to us. We need some way to be able to determine who we're going to invite for an interview. And you know, now that step one is gone, it's going to be even harder. Even in my system where they understand the rhyme scheme, and that if you're not a reliable reporter, you don't pass. If you're not a consistent interpreter, you don't get a high pass. You're not a consistent manager, essentially functioning like a late fourth year or early intern, you won't get an honors. They want that grade. They don't want the number, the language, they want the grade. So these social consequences are, I don't see a way around that. I don't think it's going to change, Dave. I think we're going to continue to have some kind of honors grade or somebody. Right at the moment, students, how many programs do your students apply to? 50?
That would be the low number.
Yeah, so if that's the case, and you know, you get thousands of applicants for your ophthalmology resident, you need something. And I don't think that even if everybody in the world used rhyme, they would believe it.
Right. But the reason that you tried to get away from grades was what?
Well, there's a lot of data talking about camaraderie among students, and actual achievement grows. That the opprobrium that students attach to a grade of C, which should be adequate, right, a pass, is overwhelming. And so what I'm trying to do is not get rid of grades, but get rid of asking teachers to rank students, which is still built into the ACGME milestones, as you know. I can't speak for scientists, but I can speak for clinicians in the clinical years. We do not look at a patient and say, oh, that's an 8 or a 7. We say that's heart failure, that's pneumonia, that's pulmonary embolism. So our data with RHYME is that it's more reliable than the shelf exam. If you ask teachers, they can do this. They don't always do it because there's still the emotional factor. That's why we talk to them. But asking teachers to rank students, I don't think is good for the student or the teacher. I think you can, you know, I often say to the teachers when we're doing workshops on this, how many of you have given a grade of honors? How many of you have given a grade of fail? How many have given a patient cancer? They say, what are you talking about? We don't give the patient cancer. So I do the Billy Crystal, you know, kind of thing, or the what is it, Eddie Murphy and Coming to America. Do you see what I mean? You shouldn't be giving, you're not giving a grade, you're making a diagnosis. So that's why we try to say, make a diagnosis, reporter, interpreter, manager. And there's always gray, right? It's not always 100% certain the patient has a pulmonary embolism. Sometimes it's just probable. So sometimes the student is not an interpreter. They're just probably an interpreter. Say, well, tell us that. And since we have 5 to 10 evaluations per clerkship, and ostensibly hundreds over the 3rd year, we ought to be able to do that. But I don't think we're going to get around grades. It begins in grammar school. It's too deeply embedded in the culture to get rid of some kind of classification.
Any other questions? Alice is sharing with us the RHYME framework is on JIT. Maybe I'm going to ask, maybe, I don't know if this will be the last question, but I'm intrigued by the idea that it sounds like one of the keys in the system is that your students match to a more limited number of programs. And I wonder, like, what the practical implications might be for a school like us. Like, should we be thinking about building partnerships with a few select institutions and really build trust? Would that have
Well, that usually happens anyway. There's usually some kind of funneling, right? Most schools, 25% of their graduates go to their own hospital. Yeah. It was 50% at the Mayo Clinic about 20 years ago, but only half of them eventually remained on it. So, but it's usually a quarter, a third, sometimes even a half will go. So there is that pipeline because they trust you. And it's often a safe school. You know, people want to apply outside just to go to some other institution because they think it's more prestigious, or they'd rather live in, Boston than in Baltimore. But in addition to those pipelines that are built, I think what Dr. Battinelli proposed is working with particular specialties. And you have specialty leaders. So the psychiatrist, what are you interested in? And we'll make sure that our MISPs, or our program, our post-clerkship standardization, our individualization in the last year or two of the medical school will address those things, and we will report it to you honestly. I would build in a lot of student and alumni work when you're revising your curriculum to do this. Because they'll give you some insights in how to do it. We say medical education is a public good, but in the United States, the costs, I have no tuition. I think you know this. Our students are paid $50,000 a year because they're officers, and in return, they spend 7 years of their lives serving the public, either in Haiti or in Afghanistan or whatever it turns out being. But they're very interested in the grades and in getting into their program of choice. That's built into us, this competitiveness. This will not change in the short run. So I think you acknowledge it. My emphasis in my whole talk has been the role of faculty in building trust of the students for the system and in helping the student move towards independence, readiness for supervised practice as an intern or unsupervised practice at the end of residency. I think just in the same way that the CEO of the hospital treats me as a clinician, as a cog in their machine, I'm worried that this is being built into as well. That somehow the 400-year tyranny of number over words in Western civilization is used. The student is being treated as we have to measure everything. And if we have to measure everything, that's what, that can be turned to an advantage if you can give those measurements to the GME program and they trust them if they're used openly. But once you move from understanding into action, from knowledge into wisdom, from assessment into grading, and again, for me, grading is not an educational action, it's administrative. You move into the world of values and what your institution represents. This is not simply a cognitive issue, how we grade. It is a social value-based. Just like when I talk to a patient with diabetes about whether they're going to take insulin or something else, their values are at play. The values of your institution and community are at play. They just have to be brought to the surface and discussed. I see Dr. Battinelli has his hand raised again.
No, that's a mistake. But I will throw one out then. We are, one of the things that we did early on was that we were concerned about our grades and making sure that we sort of looked, relative. There were a lot of things that were different about how we did the education, but we wanted to make sure that people could interpret the product. So we had a very traditional grading system. I've been pushing to move away from traditional normative standards to something other, including the ability really to differentiate earlier. And my question is really going to get about how to integrate in time variable competencies. Now, and these guys have heard me 100 times. If I say time variable to a group of people, they always think shorter. And I'm talking time variable and trying to figure out how does one get away from penalizing anybody who's not as fast as somebody else, since that's the natural confirmation bias is if you can do it faster, you must be smarter and better, when it's really how well you do it, as long as you're staying within some sort of reasonable amount of time.
Well, we've had for many years here at USIS, 5 and even 6 years. Remember, the students are not going deeper into debt. They're still being paid $50,000 a year. If they have more in med school, their commitment to the military goes from 7 to 8 years. In other words, you add another year. But I agree with you. Some students need more time. Some people need less time. And if they need less time, they could either work on a master's degree or something else at the same time. But what we tend to be doing is seeing curriculum as a hoop to be jumped over. How high can you jump? What we should be looking at is the slope of the curve. Now, some students who come in with a very steep slope and then they flatten out, that's almost always diagnostic of a social problem, right? They have a sick kid, they're hypothyroid, or they got depressed or something else like that. But there are some students who, like me, I was an English major. I failed microbiology and I had a difficult first 2 years. Still became chair of medicine, but there it is. Yeah, cheap. But the point is the slope is different depending on what your background is. And that doesn't include just college major, lots of other things, how old you are, whether you're 35 years old with 3 kids and you're still supporting, you're still trying to work another job. But I think one of the curricular things that is of most interest is looking at the slope of the curve, and there's not been a lot of research done on that in the pre-clerkship period. And even in schools that have gone from courses, anatomy, physiology, to modules, there's still a problem with one module not having the same rubric as the next module so that we can actually look at slope.
Wow.
Yeah, I'm not sure what the social impetus is behind time variable. It's an outflow of the competency-based movement. I think it was possibly an added benefit of being able to guarantee the public that we had measured everything we needed to measure and that somebody's ready for internship.
Well, and potentially concentrating on some things other than, if you're a student in a traditional medical school, with a passion to do OBGYN as a career right from the day you get in there, you'll get the same 6 weeks in OBGYN everybody else gets. It doesn't seem like the best way to train somebody interested in a particular discipline. And what's the downside of giving that person a lot more time than somebody else who's choosing necessarily not to go into OBGYN, but a minimal amount of time in something else and variable in other things?
Yeah. Well, some schools have dealt with that by having one elective during the clerkship year, and through early starting of the clerkship, starting the clerkships halfway through the second year, it allows an extra 4 or 5 months after the clerkship for more individualization. The other thing is our school, like many others, has a research project or a capstone project or whatever you want to call it. So the individualization can be through both clerkship year, selectives, post-clerkship electives, and then your capstone project. What's critical here is the mentoring of a faculty member, so that if a student is the first year and they say, I want to go into OBGYN, are they given a mentor early on so that they can start attending OBGYN grand rounds or things in their first year, But I agree with the notion that there should be some standardization, and the MD degree has to have some guarantee of generic broad competencies. Let me use that word, prior to graduation. We speak in our culture of the MD degree as a license to commit medicine, with the implications, of course, like committing murder. When you have an MD degree or a DO degree, you are potentially dangerous. And therefore, there must be some standardization, some guarantee, even before you get into residency. I mean, most medical schools have the history, somebody got through, right? Somebody graduated that we didn't know, or they deteriorated after, and they did dangerous things during internship. It's rare, but it's very, very hard to protect against that. But some standardization in the professionalism, the sense of duty. The question that we had before is how do you guarantee the professionalism of a student? And that has to be looked at very carefully.
Yeah, and in that standardization, and just in a side conversation, making sure that although you don't want to interfere with the faculty, some of our systems are set up so in such a fragmented fashion that the amount of time any individual faculty member has with a particular student can be so limited as to really not take advantage of a continuity relationship. And
Yeah,
the
I agree.
students so mistrust that short amount of time that they adamantly oppose feeding any information forward.
Yeah,
In order to help them.
sure. Well, there's a logical fallacy in that. So if I took over your service on an inpatient service next week, I could, within 24 hours, understand the patients you were handing over to me. You'd say, this patient has heart failure, this patient has a pulmonary embolism. And this is considerably more complicated than whether a student is at a reporter, interpreter, manager level. So it's kind of a bogus problem. And the other premise is that if I hand over the patient to you, the student to you, and the student really has problems, you're not going to figure it out. You know, the idea the faculty are stupid and we're not going to figure out, we'll only figure it out if somebody biases us in that direction. You know, there are diagnostic problems in clinical medicine, that heuristic biases, but by and large, clinicians are smart, so they're going to figure it out. So the students' comments are not founded based on principles, but based on fears, and I think you can kind of get around that. I think that
no, that's what I was trying to get at, the fear that and the mistrust, which then doesn't allow the student to learn as much as they could, given their job is to make sure someone never finds out what it is that they actually need to learn.
Yeah. I've consulted with some schools where the lawyers have forbidden forward feeding. We wrote a series of essays in academic medicine about 10 years ago on this too. I believe that forward feeding is a responsibility of the faculty, that you do not owe the medical student whatever kind of protection they think they're going to get. But what I'm after here is faculty are pretty smart, and I think what we can do is say that you have 4 medical students. This one's a reporter moving to interpreter, and the problem is knowledge. This one has a problem going from reporter to interpreter, and the problem is not knowledge. They know a lot, but confidence. So you and the resident have to behave differently in helping them overcome the confidence barrier. This student is already ready for internship, is at the manager level, and you should probably give them sub-intern-like responsibility. We do that all the time. And the RHYME framework is so portable, it allows us to do that. But the students need to, if there's no trust, most other things are not going to happen. It's the wrong relationship. The other big problem is in medicine anyway. We no longer have ward attendings who are there a month at a time. Even 2 weeks is unusual. So we try to have preceptors who work with the students for 5 or 6 weeks at a time to achieve the continuity. And since the ward attending should be teaching at the house staff level, not at the student level, we've committed to that for a long time. But it's harder and harder to do, trying to find the faculty who can spend that 5 hours a week with medical students.
Well, Dr. Pangaro, I'm going to thank you. It's 6:30, and I think we could go on for another 2 or 3 hours at least. Thank you so much for allowing, sharing your thoughts, giving us so many things to think about. And I can see from the faces, I could see from the chat that people are intrigued. So thank you again. I think that Dr. Ginsberg is going to make one last request or offer to our audience.
Thank you. And thank you again so much for a great talk. We're just going to drop a couple quick things in the chat to let everybody know if you are interested in signing up to participate on one of our curious questioning teams. Today is the last day. So you can please sign up if you would like to be placed on one of those teams. We're going to get those teams started very, very shortly. We have a great talk coming up on December 7th. We have a team from Apple who is going to be with us, and they're going to be sharing with us a lot of very, very cool and exciting innovations of the use of iPhones, iPads, Apple Watches, and whatnot in the clinical environment. And on December 15th, to round out our academic year, or calendar year, I should say, we have Dr. Cunningham coming from Columbia to speak with us about promoting an anti-bias and inclusive curriculum. So really great talks coming. We thank you for joining us tonight, and we hope that you will be able to join us for some of these upcoming talks. And thank you to Dr. Pangaro for
Thanks again, Lou.
You're welcome. I will send a copy of my slides and an annotated bibliography. And if anybody wants to email and have a chat in a week or two, I love talking about this stuff. And you guys are great. You have a great school, a great institution.
Thanks
You're
very much.
Very lucky to be
Sure.
there.
Thank you. Happy and healthy Thanksgiving to
Yes,
everyone.
happy Thanksgiving.
Thank you.
Happy Thanksgiving,
Okay.
everybody. Bye.
Happy Thanksgiving.
Bye-bye. See you, Judy. See you, Elizabeth, tomorrow.
All right.
a good night.
boys.
Thanks so much.
Bye-bye.